I want to draw your attention to the Narcan that is in your bag at your table. And you may think this is an odd choice of gifts at a pediatric conference, but I want to tell you a little story how we kind of got in the business of giving Narcan and why it's so very, very, very important. And this is something that hits close to home. For me, I lost my brother to an opioid overdose, and it started with a prescription pain pill, prescription for pain pills because of a hurt back. We are currently in a project to employ life care specialists, which is a brand new part of the healthcare team. And they're the folks who address pain when a patient comes into the hospital. And how this was all born is that we became friends with Cammie Wolf, and she is the CWC Alliance, and her son at the age of 14 had a chronic condition and went in and started a series of abdominal surgeries. At that time, opioids were brand new. And I don't know if you all can remember, if you have a little age on you like I do, you know they were introduced as the miracle, and they're not addictive, and they're the bee's knees, and everybody needs to have them. And we were encouraged to give them like crazy. And it was the greatest and latest thing. And so he left the hospital with 120 of them, followed by another prescription for 120. Then 18 days later, he was back in the hospital for another abdominal surgery and he had 8 of them. And over the span of 3 years, he was taking opioids continuously. And so you know what happens when that happens. And so Cammie says his brain was hijacked. And it started a 14-year battle with opioid addiction. And at that point, they thought that he was doing well. He had been in recovery for several years and died by overdose. I had a similar story with my brother. He hurt his back, got a very large settlement, had a very large addiction problem, and died because of that. I don't want that to happen to any other families, but it is an all too common story. You know, you see it. You see it on the front lines. I was talking yesterday to a PharmD in a rural community. She said, you know, we talk about young people all the time, but we don't talk about the elderly. They came along when this was the thing. And so she said, I can't tell you how many elderly patients I'm trying to get to detox off of opioid prescriptions that they've been taking for years and years and years and years and years. And they then become forgetful of if they've taken it. So then they take it again and they end up in the ED with an overdose. So that's why this has become our giveaway. It's very personal for me. If you haven't been affected by this, I'm so grateful. I'm so grateful. But chances are you know someone. Chances are you love someone that has been affected by the opioid crisis. This is one small thing we can do. Everybody can use this. It's easy. You can teach your 16-year-old how to use it. You can teach your grandmother how to use it. You're not going to hurt somebody if you give them this, but you may save their life. You may give them another chance. You may give them a chance to live. So it's very personal to us. We're very excited about this life care specialist. It was modeled after a child life specialist. And it's that missing part of the healthcare team. We're currently getting these folks. We're getting 2 into 6 rural hospitals. And we've privileged to be able to get a $1 million grant from the Rollins Foundation, who thought this is just what we need. We need to try this. It started in Grady. It has seen great success in Grady. We know it's going to be an important and big deal for rural Georgia. So I want to see them. I want every rural hospital to have this part of the healthcare team that a lot of nurses say to us, we got into healthcare to do the very thing that your LCSs are doing, but we don't have the time. We do not have the time. What we've got is a dose of pain medicine. But if we had any other options, we want to employ that. And so that's what these LCSs are out there doing. But in the meantime, until we can get those folks to you in your hospital and in your community, I'm sending you home with some Narcan. If you need more, there's more over here on the table. If you want more for your community, let us know. We have thousands of doses in the center. Last year, we had an influx of money and we knew just where to spend it. We want these in our rural communities. We don't want you guys to have to talk to families about the death of their loved one. We don't even want you to have those discussions about addiction, but it's already there. It's already there. And people think, oh, no, not my loved one, not in my community. It's already there. So let's have these frank and honest conversations with our kids, with our adult children, with our elderly loved ones, and give them Narcan. It's easy to use. It's readily available. If you don't have a means to get it, call us. We'll get it there. My goal also is to get it into the hands of every teacher that's allowed to have it. I tell them, if your school system doesn't let you have it, put it in your car. Put it in your glove compartment. Nobody has to know until you need it, and then they'll be glad you got it. So it's the greatest weapon you have for the front lines until we can get a hold on this crisis. So that's my little plug for this. If you need more, come see me. I'll be glad to get it in your hands. Thank you.
There's a trope in ministry that you never go to anything without having a sermon in your pocket. I had no intention on speaking today, but good morning. I promise I'll make this short. If you'll look in your folder, there is something called Faith in Rural Health. And I would love to draw your attention to that just for a second. On October the 4th of this year, we are having the first ever Faith in Rural Health Summit right in this room. And I would like to just whet your curiosity if I could. We have for the last 2 years in several rural counties been building collaborations between faith leaders and healthcare providers and getting them together to think about how could we together think of ways that we could improve the health in our communities. And it's been so much fun. We have worked in Putnam County. They've had health fairs together with the hospital and with churches of all denominations and with the clinics there. We've been working in Berrien County where we've done some really neat things with youth med camps. We're now in Coffee County and Evans County and Toombs County. And we have noticed that ministers and healthcare providers have many of the same interest in their community, but they really don't have a way of working together. And as we've explored in our communities, we've noticed that when we get them together, it's been really refreshing and life-giving for those practitioners and those communities. So we're going to be talking about that. And one of the things we're trying to do is, if you're a minister, we're asking you to find a provider in your congregation or in your community and bring them. And if you are a provider, find a minister that you know and come and bring a buddy to the Faith and Health Summit on October the 4th. We would love for you to register. The registration is open now. Take a minute and think about that. And if this does not apply to you, surely you know a practitioner or a faith leader that would be interested in this. Thank you and blessings.
Thank you, sir. Thank you so much, Paul. We now will have some information shared by another colleague, Ms. Joan Anderson. You can clap for her as well.
It's a long walk. So we want to share about our third annual Maternal Health Symposium. It is June the 20th. It's a Thursday, and we'll open the doors at 8 o'clock, just like today, and start about 9 with our programming. This year, our topic is the maternal health care team, and we have everyone from MFMs to OBGYNs, to doulas, nurses, breastfeeding specialists, coming and sharing what it's like to be on that team, how their interface, what their roles are, what's been successful, and how to collaborate, because it's the continuity of that experience. Last year we talked about the life cycle of maternal health, and we started with the baby. And Dr. Tarbutton spoke with us. If you start with a healthy baby and child, then you have a healthy adolescent, and you just kind of go on the whole life cycle. And because wellness and health is somewhat intergenerational, it's really important for each generation and each phase to be healthy. Because if you show up and say, I'm pregnant now, it's time to get healthy, it's kind of late. I mean, it's not impossible, but it's better to live forever the healthy lifestyle. And the other thing that we've talked about is that in rural communities, it's so difficult to have a complete portfolio of all the different healthcare professionals or roles that may be available in an urban area for that pregnant mother. Look at how many of our rural counties do not have hospitals, and if those hospitals don't have birthing centers. Look at the number of rural communities that don't even have an OBGYN. So there is a lot of need. And so we've got, I forget the exact number that have to, what is it? The majority of our rural mothers they have to deliver at least 30 to 40 minutes away from their county of residence. And we have a colleague of ours that works in a rural community who recently had a baby. And he's saying, I was born in this community. I've lived in this community my whole life. I've returned to this community, and my baby's not going to be born in this community. And so there's a lot of things we're looking at. We also have an observership for maternal health. Okay, you can talk about your thunder. But anyway, what we do is that we have the maternal health symposium during the week where we start our observership. So we have students that we're schooling and are creating programs for viability in rural communities. And what the maternal health symposium does is try to generate those folks who are actually providing the care to come forward and to have a collaboration of what are some best practices, what are some ideas, so that women can safely have their babies. And we know that those in rural communities have a greater maternal mortality. And unfortunately, the United States has horrific maternal mortality to be one of the first nations in the world. And Georgia, God bless us, we stay in the bottom third of the 50 states. So there's a lot to work to be done, and we want to share information with you and have you come forward and share information with us so that we can make a difference and our moms can live and our babies can live.
Thank you so much, Ms. Joan. So now we will begin our Lunch and Learn panel discussion, which will highlight lessons from rural Georgia pediatric providers, particularly looking at innovative ways to address patient challenges. You are in store for a treat. We're privileged to have 3 pediatric providers from our first cohort of the Children's Healthcare of Atlanta Partnership Program. And as I call their names, I would ask that they would come and get comfortable at our fireside chat seating. So first up, we have Dr. Grace Davis, who is pediatrician at Sylvester Pediatrics and Adolescent Medicine in Worth County. Next up, Dr. Brittany Lord, who's pediatrician at Eastman Pediatric Clinic in Dodge County and New Life Pediatrics in Telfair County. And then we have Dr. Jennifer Tarbutton, pediatrician at Children's Healthcare Center of Sandersville in Washington County. How are each of you all doing? Well, great, excellent. All right. So as we engage in conversation, I do have a few questions that I'll ask of the panelists, and then we will open the floor to all of you to ask any questions of them that you may have. But first, by way of introduction, if each of you would describe your pediatric practice and county in which you serve.
Good morning or good afternoon. I'm Grace Davis. In solo practice in Ward County. I thought I was loud enough. Yes, I'm in solo practice in Sylvester in Ward County. Ward County is in south central part of the state, and it's about 20 to 21,000 population. Sylvester has about a population of 10,000.
Yes, I'm Brittany Lord, and I am a pediatrician in, we have an office in Dodge County with the Eastman Pediatric Clinic, and then we also serve Telfair County at New Life Pediatrics in McRae, Georgia. And I am thankful to have the creator and the owner and my partner with me, Dr. Johnny Peoples. He's here too.
I'm Dr. Jennifer Tarbutton. I'm a pediatrician in Washington County. And Washington County is in the southeast part of the state. We're an hour east of Macon and an hour west of Augusta. The county seat is Sandersville. That's where I live, and our population there is 7,000. And the practice where I work is a hospital-owned practice. It's owned by Washington County Regional Medical Center.
Great, thank you all for those introductions. So by way of data, just to talk some numbers, approximate numbers at that, during the time span of 1 week, how many patients do you see?
On average, about 80 patients a week. I'm open Monday through Thursday all day, and then Friday mornings, I only do walk-ins. So it varies.
So similar, about 75 per week. We do have other mid-levels and other providers in our office. So in total, we may see around 300 to 400 per week.
I was talking with my office manager this morning. So our practice, I work 3.5 days a week. We have another pediatrician there a day and a half a week, and we have 2 mid-levels who each work 4 days a week. And on our busy winter months, we're between 400 to 500 per week. And during the summer, where we're doing more health checks, we're 250 to 300 per week as an office.
So we asked that question so that you as the audience will kind of know what you're looking at, the pediatricians, as far as how many patients they're serving on a weekly basis and where they're physically located. When it comes to the providing care to your patients, what would you say has been your greatest pediatric clinical challenge of all times? If you could think of just one or two, what were your greatest challenges? And then also, how did you respond to them?
I was trying to figure which one, because almost every week comes with challenges, and sometimes it's every hour. But I think one that kind of shows you what rural life is like. About 10 years ago, a mom called, brought the child one afternoon, because we do a lot of walk-ins. And the child was a kindergartner. She had fallen in her classroom before lunch that day. And mom brought her in that afternoon because she had a little soft swelling on the forehead. And the nurse had said put ice on it. And the kid, neurologically, I promise you, she was fine. She was fine. 2 days later, the mom called because a little girl is crying that her head hurts. So, 48 hours, like, it couldn't possibly be a head bleed, right? But I said, okay, I'm gonna send her to Albany. Somehow I got a stat MRI without contrast of the head. Remember I said it's after school that she came in, right? So that night, the Nighthawk called from somewhere on the globe to say that, oh, she has a brain tumor. Okay, that's bad enough, right? Not quite. Because right around the same time, our county was having problems with ambulance service. So Ward County is a large county. At the time, we had 2 ambulances. There were issues getting people picked up, transported even just to Albany. That's an ongoing problem. But I had a bigger problem because I had no phone number. Because the phone number I had, It didn't work. The phone number that they registered with at the hospital did not work. But here's where you have to become really, use your wits. Resourceful, thank you. Okay, all right, I know who knows them, who they live close to. So can so-and-so go to the house, knock on the door, tell them to get in touch with me. Tell them to get in touch with me, knock on the door, get in touch with me. It's at night, we're having ambulance issues, we're 3 hours away from Atlanta, but I did call. While I'm doing that, I'm also calling Choa, the neurosurgeon on call, who said, hey, we gotta get a child to Atlanta. Talking through with the parents what had to be done, the child has to go to Atlanta. They did not feel comfortable trying to figure out the ambulance situation. They decided they were just gonna drive to Atlanta on 75. The neurosurgeon also told me, make her NPO. Really? She's 5. The problem is, on the way to Atlanta, there was construction going on. So she's supposed to be NPO. So of course we had to do the popsicles, ice chips, all of that. At the end of the day, she did get to Atlanta that night. She had surgery the next day. She spent about a month in at Scottish Rite in rehab. But again, these are just, there are always more than one issues that will compound everything, and you just have to be able to know your resources and work within your community. Because for rural medicine, you have to know your community.
Yes, so we talk a lot about in rural medicine that, you know, our patients, one of the greatest things that we face is patients having access to healthcare or not wanting to drive. But I feel like even when they do have access, sometimes they're still non-compliant and they still don't want to go. So for example, so I think this was probably maybe within my first year of being down in Dodge County, and we have in McRae, there is no hospital at all. The closest one is Dodge County, which is about 30 minutes away. So we have a mom in our, that comes to us, and she is a known drug user. And she came, I got a call, I was working in Eastman, my nurse practitioner was working in McRae, and I got a call from my nurse practitioner and said, she just walked in with this baby that was 3 days old. We had no idea she was pregnant, no prenatal care, had this baby at home in her bathtub, delivered the baby. And, you know, we've heard this is like, I mean, on test, like a test question. I mean, cut the cord with a knife, that she probably found, probably was not clean. And I'm sure she, obviously delivered her own placenta, and I'm glad she didn't, bleed out or anything like that. She probably was on drugs at the time. But waited 3 days and then just showed up to us with this baby. And then my nurse practitioner was like, well, what do we do? And so, I'm thinking about all the things that we usually normally would check for in the nursery. And, we have no idea if this mom has any STDs, probably so. What drugs was she using during the pregnancy? So, of course, too, I'm like, well, let's also call Dr. Peoples because he's been here longer than me and we know our resources. So we kind of worked with the health department and kind of called all over to, help make sure we can get the vitamin K shot, our eye drops and the newborn screen. How do we do that in the clinic? And the reason that she had the baby at home, number one, drug use, but number two, she was so afraid of the ambulance because one of her other kids, something happened and went in the ambulance to Dodge County and passed away. So in her mind, she associates the ambulance with death. So she did not, even when she was having the baby, she did not want to call 911. Did the same thing, with another baby, but this time we were prepared. But it's just a challenge that we face, access, but then also, just trying to get our patients to understand, get over those fears and just even when they have access, please use it. So that's one of the things we face.
My heart is beating fast thinking about both of y'all's situations, and even more so the memory of this one that I'm going to share with you guys. I can remember very clearly. It was July 21st, about 8 years ago, and the reason I know that because my middle child's birthday is the 22nd, and as I was finishing up my summer work day in the office, I was anticipating getting her birthday party ready. So the morning of July 21st, I have a friend who was moving from Atlanta back to Sandersville with her 1-month-old baby. She also had a 3-year-old at the time. And she brought the baby in for a 1-month checkup the week before, and he was totally fine, healthy newborn. And on July 21st, she brought him in the morning, that morning, because he had been spitting up more than normal for about 12 hours. I did an exam on him. He looked great. Had gained weight from the last time I saw him. This is a really good mom with good intuition. And as I examined him, I remember saying that he must be having reflux because he was spitting up after the bottle and he still had good weight gain. And I talked to her about reflux, but something on my radar knew she was worried. And that worried me because he looked good. So I said, I tell you what, I think this is probably reflux, but when I get to the end of the workday, I'm going to give you a call and check in. I said that just because of how she was acting. And I had one patient left in the room, and she came flying through the door with the car seat and said, something is wrong. And I picked her son up out of the car seat, and he was floppy and cold feeling. So we got called my nurse. We got a pulse ox on him. We got a rectal temp, and his temp was below normal. So I began to assume that he was septic. Our hospital that owns our practice is immediately across the street. And this was now about 4:15 in the afternoon. I called the ER. I said, I think I've got a septic baby on hand. I'm sending him over. This is what I want you to do. Start the IV, run a bolus, get these labs. I'll be over there in a second. Thank goodness my last patient that day was an ear infection. I went in and out of that room fast. I ran across the street because I knew that our ER doctor had no pediatric experience. And he was an ER doctor that traditionally wasn't great with kids. So headed over there, they were getting the bolus started. The baby was starting to deteriorate, and I knew they still had a house in Atlanta. I called Children's Health Care of Atlanta. I said, can y'all please send a helicopter? I've got a kid about to code. And they said, it's July 21st. Our humidity is too high to fly the helicopter. And so here I am in a little rural hospital. I'll probably get tearful saying this. I do think God had a hand in this situation because I had my best respiratory therapist on hand. Our best nurse anesthetist that can intubate kids happened to be in the parking lot. She had not left yet. We ended up intubating him. We ended up starting CPR. Called because the Children's Hospital and Children's Health Care of Atlanta's PICU was full that night. So I called the Children's Hospital of Georgia, and they said, well, we can't fly a helicopter, but we'll start an ambulance coming. We'll be there in an hour and a half. So we got him intubated. We started CPR. They put me on the phone with the PICU doctor, and she said, get a chest x-ray and send it to me. And I sent it to her, and she said, this baby has a really enlarged heart. I don't think you're dealing with sepsis. After our first bolus, his blood pressure started to go down. She said, you're dealing with myocarditis or, some form of heart failure. She said, call the pharmacist and see if they have this medicine on hand. So we called up to the pharmacy. They had not left for the day yet. They had the medicine on hand. The PICU team described exactly how to administer this medicine that we never do in our hospital. And the baby survived. and he made it to the PICU, and they said he had viral myocarditis for an unknown reason. And they said that a third of the babies will die with that, a third will survive but need heart transplant, and a third will recover. And this little boy is totally healthy today. So that is the one that I'll never forget.
Wow. What profound experiences and challenges that just the three of you all have experienced in your pediatric careers thus far. And not to mention, we have a room full of pediatric providers that have had experiences in clinics and hospitals and other settings across rural Georgia. One key thing that I do want to mention before we go on to the next question that I was able to gather from each of your responses talking about your challenges is that from each of your experiences, you used one of the 3 R's that Dr. Greenbaum's presentation covered earlier. That was resources. You got to know your resources in your rural community. Also, referral, being able to reach out to Children's Healthcare of Atlanta and rely on their experts and their subject matter physicians and specialists to provide everything that you needed, information, knowledge, direction of how to use that medication that you had never administered before as well. And also recognition to your patients to have a better understanding that the ambulance is not a signal of death, but it's actually a signal of hope and help to meet the need in whatever emergency situation that arises. Continuing on as we talk with you all, have you ever encountered challenges with parents or guardians of patients? Now, we know every parent is the best parent ever, right? They love their child and they love their pediatrician. But sometimes that love and that passion can exceed what a parent should express in words and in actions, maybe. I don't know. So as a pediatrician, have you ever experienced a challenge with a parent or guardian?
Again, that's an everyday thing. Which one? The pregnant teenager who can't tell her mama, the foster parent who wants the child sedated because the behavior is too bad. So it's like, which one? But my pet peeve is more with the foster system or foster care system, and I'm thankful to God we have a good foster care system. However, trying to get a lot of our foster parents to understand that the behaviors that the children are exhibiting are normal reactions to being taken away from what they know is normal, and you are a stranger. And patience is the key, and not medication is a necessity. And just working gently with the foster parents and helping them learn to de-escalate situations. And because of where I am, and just like a lot of us, it's limited resources. So unfortunately, I have to be the untrained social worker, which I've been doing for 30 years.
So, yes, as she said, it's an everyday, parent challenges are everyday, but I have one example that's kind of just stuck with me because it was the first time that I was like super uncomfortable in the room. But so I have this patient who I cannot remember what happened to his mom, but his granddad is raising him now, and his granddad is not the most sensitive person, very just harsh, but he marched up to the front office one day and just demanded that I give him an order to test his grandson's hormones. And so, not knowing why, I said, well, let's make an appointment because we need to discuss that further. Well, I think he let the front people kind of, know that he was not happy about that, but he made an appointment. And so the day came for the appointment, and I just knew like this could go either way, 50-50. But sure enough, as soon as I walk in the room, I mean, he was ready to fight. I mean, I sat down, hello, how are you? And he just laid into me, why do we have to be here? Why did you make me have an appointment? I have to have an appointment just for orders and just for labs. And I mean, yelling to the point where I was glad I was by the door because I didn't know what was about to happen. And he's a big man. And so, but in that moment, I just, I don't know how I did, but I kept my composure because I'm not going to say inside I was not like, thinking things, but I just kind of kept my composure and I just let him let him say everything he wanted to say. And then, I just talked to him. I said, well, I need this appointment because I need to know why do you think something's wrong with his hormones? Let's get to the bottom of what's going on. How is he acting? And, I think once I explained that to him and why I wanted him to have an appointment, we started talking and saw that there were bigger issues. It wasn't just his hormones. I mean, we ended up talking about mental health problems, other things that, I actually ended up having to refer him to a specialist. So I think once we started talking more, I think he realized that, why an appointment was needed. And I just going forward, any other parents that kind of get mad, I just think about that because our parents, I tell my teenager patients, well, any patients that are getting bullied in school, when someone's bullying you, it's very hard, but try to ignore it because usually the person that's doing the bullying, there's something wrong in their life. They're angry for a reason. They're taking it out. Now, some kids are just mean to be mean, but for a lot of times, they probably don't have the best home life. They may be getting yelled at home or verbally abused at home, and they don't know how to handle it, so they take it out on someone at school. So I think about that, and parents, well, why are they angry? They're angry. And this man, he was angry because, he's a grandfather working hard to take care of his grandchild. He had to take time off of work to come. He had to pick him up from school early to come. And he just didn't understand, why it was important. So I just think about that now with my parents going forward. Just try to stay calm and try to explain things to them and understand why they're upset, and then try to explain, my position to them as well. And now when he comes to see me, I just saw him the other day. He acts like he's known me for years, and he asks about my kids, and we're like best friends now. So I'm not afraid of him anymore, but yeah.
You mastered that one. I agree with Dr. Davis. Which parent? It is a challenge. I did, though, with preparing for being on the panel, think through one in particular that stood out, and it was one of those times where you can kind of feel the sweat building up under your arms. But this was a young mom who has one child, and she was in my office with her 5-year-old in July for an ADHD assessment, insisting that her daughter had ADHD and that she would never be successful in school. And we do require the Vanderbilt assessment forms, and of course, in July, she didn't have them with her. And I told her that it probably wasn't the appropriate time to do the screening and that we could come back after school got started. Well, over the course of the visit, I realized that the mom was mentally ill. And she sort of had flight of ideas and wide range of emotions in the room. And the more I talked, the angrier she got. And the fact that I wasn't giving her exactly what she wanted, the more upset she got. And really, it crossed my mind in the room, I sure hope she doesn't have a gun or a means of a weapon that she could use on me, because it got to the point that she was just that off. So I think the way I handled it, I tried my best, although I didn't reach the same, I wasn't quite as successful in making her my friend by the end, but I did use the small town tactic of thinking of other resources, and I realized that this mama really needed help. And I asked her if she had a primary care physician. She shared their name. So after she left, I called her primary care physician and said, I'm really worried about this mama. And they were able to get her in they were not able to get her help, so we made a DFACS referral. And I think after that, and then I think she has since had some help, and it was she that needed help more than the child. So.
Awesome. Thank you, each of you, for sharing of those experiences. Obviously, we can tell that each of you had to be strong in your own way as you engaged with those challenging parents or guardians. But what would you say is the greatest strength when it comes to pediatric care across rural Georgia?
I think rural Georgia in and of itself is a strength, because especially in the world of pediatrics, unlike adult medicine, we're not trying to fix things that have gone bad. We're actually in the business of preventing. And rural families tend to be more family oriented, and they do have an attitude of they want to do it themselves. And that I find is very helpful in practice in pediatrics, especially when we talk about how we incorporate lifestyle changes into improving outcomes. I find that my parents, they tend to be far more receptive, even though, yes, some people do want that quick fix and they do want a pill, but spending the time, and because when you're in a rural practice, you actually become part of the community, and there's a trust that develops where they actually will listen to you. And it's a partnership. But there's a downside too, because the downside is if I'm talking to you about obesity, diet, diabetes, and we're in Walmart and I look in your shopping cart and I saw you run the other way with your shopping cart, I know, I know what's going on. Yeah.
For sure. Yeah, they try to hide from us.
Yeah.
In the Walmart. Sure, yeah. Yes. I think going off of, because we are limited in some of our resources and our access, I feel like one of the beauties of rural pediatrics, rural medicine in general, is that we as providers have such a passion. I'm not saying that urban providers don't have a passion, but it's just like we have a passion to fight for them and to make sure that they get, whether if it's we have to call Atlanta or we're having to call in the middle of the night, or whatever we need to do, call a neighbor, call someone that, we're going to do it because we feel for them. And we feel like, in rural communities in general, everyone's close. Everyone knows everything about everyone. And then, our patients do become a part of us and like our family members. We go to each other's funerals, when we're sick, they ask us, how are you doing? They may bring us soup so I just feel like that's one of the beauties of rural medicine. One of our strengths is we're so close-knit that we just have a determination and a drive like none other.
And maybe that isn't it called the bystander effect, when you're in a large crowd and nobody does anything, but if you're the only one there, you feel more called to. Isn't that a term? I wonder if that's, we have more feeling like we're the only ones that are going to recognize this a little bit.
So I say to two of my colleagues, I said, if not us, then who?
And just a little plug for Mercer, I think another strength to be able to be in practice right now with this Mercer and CHOA initiative going on, helping us to collaborate is a strength right now for us.
Awesome. Thank you. Is there an opportunity? We like to use the word opportunity rather than weakness. But is there an opportunity that you could foresee within pediatric care in rural Georgia?
I think the opportunity has already started with the Rural Health Scholar, getting students, medical students, even pre-med students, out to rural areas so they can experience, especially when they come from these areas, so they can experience it and the good and the bad, and they know what to expect, because there's more good than bad to it. I've been doing it for 30 years. So, and I've done, God has been good, because I hate to sound like this, but I said, if I close my eyes today, I would not have regretted what I've done.
one thing I think about for an opportunity, which is why I'm really enjoying, meetings like this, is I think we as rural providers, we are on our own, but then we need to recognize that we are not alone in being alone. So we know that we have each other, and I think we need to, and make these connections and reach out and learn what kind of resources our neighboring rural provider has, because it may be something that we can use, and we may not be aware that even existed. Or even if we just, call each other and say, hey, has this ever happened to you? What would you do? I think that's one of our strengths that we can band together. And I think, this program and these meetings is helping us do that.
I'll just tag on exactly to the same things that you guys have been saying. I think of the opportunities through telehealth that were talked about by Dr. Greenbaum this morning, how much that is going to bring to us, and innovative ideas such as the mobile audiology suite and some other mobile. I know Children's Healthcare is doing some mobile pediatric resuscitation training. Those types of things are real opportunities that have started already.
Excellent. Our final question, then we'll open the floor to all of our attendees here at the conference. Is there any advice that you would share with pediatric providers in creating innovative ways to do what you do? Any advice that you would share?
Well, I kind of cheated when I started because I had done a maternal child health MPH program before coming. I did it during residency. But I did a needs assessment of the community prior to going. So even how my practice is structured, it's literally based on the community's needs. Where, for instance, I know my no-show rate is well over 50%, but that's okay because the walk-ins are so much. But it also means that I end up having to do things that, like if a child comes in for a runny nose, but they haven't had their shots, you're having to do all of that, and that's okay too. So knowing your community, a needs assessment, it doesn't have to be formal, but at least have an idea of what their resources are and what your families are able to do. And one last thing I did too, which I do frequently, is in each family, know who the key people are that the families will listen to. For instance, at the beginning of the flu season, I tend to try to reach out to the main people in large families to kind of talk to them about the flu vaccine, because I know I'm competing with Facebook, TikTok, and everybody else. So if I can get that main person, one or two people in a large family who people listen to, that's who I start out with.
So I grew up in a rural area, and then I saw the medical obstacles firsthand, which is why I wanted to go to Mercer Medical School, because that's their mission statement, is to serve the rural areas, which is what I wanted to do. So that's how I ended up in a rural area, that I knew nobody in, and thankfully met Dr. Peoples. So living in a rural area, knowing those obstacles, but then being on the other side and having to fight those obstacles as a provider is totally different things, or not totally different, but just a different challenge. And so when I moved to Eastman, I learned a lot from Dr. Peoples and watched him, and something that I have learned from him and I still try to do is to learn. He still learns every day. He's still learning, he's still growing as a physician. When he does have to consult a specialist and they tell us, okay, well, for this problem, these are the initial labs. I mean, he locks that in his mind, and so then he can try to be like the specialist or mini specialist next time and go ahead and know what to do, or go ahead and get these labs ready. And so I really appreciate what he does and learning that from him. So I would pass on that advice to all the other rural physicians as well.
I would say also, don't ever forget the importance of a really good history. If you can collect a good history from the parent or the child or the grandparent, that is more than half your battle in diagnosing patients.
Thank you all so much. We do have a few minutes for any questions from our audience. Going once, going twice. Yes, sir.
It seems like all your stories in the beginning were unbelievable, and so they all required so much outside of like your working hours. And and we're clearly so happy to do it. But have there ever been times where you've had to set boundaries, like where it's like, hey, no, like I'm with my family, like I'm not going to answer the phone for a patient during dinner, or how do you deal with it, work and life being so blended together?
I should not go on the record of saying this, but there are no boundaries. That's not true. There are boundaries, but I do silence my phone, but then I'm also texting. So, you silence your phone in church. You know what I'm saying, but it's still on. But parents also, believe it or not, they do recognize that, because I'm a solo practitioner, but I don't get that many interruptions at night. Parents tend to wait, and they also know when to access the emergency room. And they'll call me from the emergency room and text me and say, oh, we're here, or we're there, or we're going somewhere. But that's with time. So if somebody does call at an off time, it is a real emergency generally.
So, they talked in medical school all about physician burnout, and it is a real thing. So you have to set boundaries, or you will burn out very quickly. And so we were just talking about this the other day, actually. So, if it's, after hours and somebody does call my phone and it sounds like, an emergency or it's important, of course, I'll call them back. But I mean, they know even if it's, sometimes they'll do it even during work hours when the office is open. And then if it's just like a runny nose or something and I'm with my family, I mean, I know it can wait, until I need to respond. But, and then there are those, I have a mom who, her son passed away at 9 months with cancer, and she has my number. He has a sibling, and she'll text me a lot, and I feel like the need to just quickly respond to her. But she texted me one time when my mom was very sick, and I knew it was an emergency, so you just have to set those boundaries. So I just had her call the office or wait.
I remember when I moved to Sandersville and I was a newlywed and we had a baby like the year after we married. I remember saying to my husband, I'm going to set these boundaries now. And it probably was a month later. I thought, are you kidding me? Like, you can't do that. You're in Walmart. We all shop at the same grocery store. We, all go to the same pharmacy. We're in the same downtown area. All the social events most of the town goes to. So I think it is a push and pull throughout your career. And sometimes I'll try to set a boundary and then I think, oh gosh, I really should have responded to that. So the next time I'll answer quickly and then it's a silly call. So I don't know. It's a live and learn kind of situation.
And what's amazing, because parents are so forgiving. So even if you ignore them, they're fine.
I will say too, like just coming to the Mercer graduation ceremonies and you take your Hippocratic oath every year, it does there is a lot of reward that comes from helping those in our community and then the appreciation that they have. My children are still at home and none have graduated yet. So I do have moments where I think, oh gosh, am I ruining them by answering these phone calls, or am I showing them how to be a servant to others? And I don't know. They asked me that in 20 years.
Great. Any other questions? Yes.
Hey everybody, and panel. I'm Christina Cheek. I'm from Valdosta, Georgia. I represent Sandersville Birth Initiative. I'm a perinatal health worker based in the community. And my question is, what is your advice or recommendations as a community health worker? I am a doula and lactation counselor and childbirth educator, in order to form a partnership or come together in order to improve health in our settings, just to bridge that gap and have that relationship. So in what ways do you work with other community health providers that are in a non-clinician role or whatever to improve your outcomes in your community.
It can be formal and informal. Much of what I do is informal, but I serve on different boards in the community, so it's sort of formal and informal at the same time, working closely. I know many of the teachers at Worth County School System. I know the local pharmacists. So even I had a pharmacist the other day, for instance, that called, and really, she was concerned that one of my parents was having postpartum depression because she worked for the pharmacist. So so those are the kind of relationships where we talk about resources where people will reach out.
And I would say, so we are so busy a lot of times. We may forget about a certain resource if we haven't, heard of it for a while or used it. So even just like dropping by the offices every now and then, meeting face to face, it kind of sparks something, a memory in us. And and then talking with, our referral coordinators and things like that. I think that would help as well. Just kind of meeting face to face.
I agree. I think we're all doing the same types of things. I serve on the board of our Washington County Health Department, and we have a literacy initiative going on in the community and a mental health initiative in the community. So I'm sure you guys are like this too, as one of the only pediatricians you get called on to serve on lots of these committees. And I think that's probably the best way that we have outreach in the community.
Great. Well, Dr. Davis, Dr. Lord, and Dr. Tarbutton, we thank each of you very much for your contribution in our panel discussion today. I think I can speak for our audience. We learned a lot, we laughed, and even teared up a little bit, but that's all a part of the journey. So again, we thank you so very much, and we do have a presentation for the three of you all.